Hey guys, I'm Dr. Paul Lynch.
And I'm Tori McJunkin.
And I'm Camilla Binks, a nurse practitioner.
Thanks for joining us for the Pain Show. Many of you guys joined us on our last episode where we told our story of why we went into pain.
That's right.
And if you didn't get a chance to see that, I recommend you go back and watch it. It tells a lot about Dr. McJunkin and myself and why we started all this. Today, we're going to get into comprehensive care. We've asked Camilla to join us.
Thank you.
Camilla is our clinical director in our Scottsdale location for Arizona Pain. And we're going to talk a lot today about comprehensive care and how we work as a team.
Yeah. So one of the things that I think is pretty funny is back when we were in our fellowship, you had this one opportunity to speak to the big Texas Pain Society, and you could speak about any pain-related topic.
Yep.
And so what's funny is during that, remember this is 15 years ago, during that time, Paul and I came up with a brilliant idea. He was going to talk about opioids and like the coming opioid epidemic, which no one had ever heard of. It wasn't, and then I was going to talk about alternative and complementary therapies and like how they
acupuncture.
Yeah, how we could use those things together with pain. And then so I'll let you tell more of that.
What I think is funny, and we thought it was like the greatest idea ever. We were going to talk about, how acupuncture works and chiropractic care and naturopathic medicine, and homeopathy, and like we had all these ideas. And I think the way I remember is you went through all the literature and were like, well, these are the 2 or 3 I really want to talk about. I think you even talked about biofeedback.
Yeah, I talked about biofeedback. Ton of research on that. Prolotherapy, like all these innovative alternative things.
And so then like Tori gets up to give this, this speech in front of a couple hundred people. And it was like, what is he talking about? Like it was almost like they were angry at us.
What year was this again?
2007.
Okay.
Yep. So it was completely foreign to them, and like they were not ready to embrace chiropractors, physical therapists, like anybody. Like it was like, this is our one track. We do medicines and injections, and that's all we do.
Right.
And so it was a good presentation, had all the literature, but I talked about how those things actually help people and how we should be using those things in our everyday practice.
I knew you and I were different at the time because everyone in the room was questioning what you were talking about, and I was like, guys, this makes perfect sense. Like it's comprehensive care, it's integrated care. We're not saying that only you do acupuncture. We're saying that acupuncture might support Western medicine and some of the other stuff that we do. You and I have always seen, eye to eye on that, but not every, doctor, does. And so as we started our clinic, I remember us brainstorming like, this is the kind of clinic we want.
Yeah, exactly. Yep. So yeah, I told you before that my dad's a chiropractor and naturopathic doctor. Your dad is a therapist and does biofeedback, and so we had this interesting background, I think, just on our own personal backgrounds, and we knew that if we could integrate that into a clinic, that it would really help a lot of people.
So we're going to bring Camilla into the conversation, and so if you fast forward 15 years later, tell us a little bit about what a patient would experience at an Arizona Pain Clinic today.
So typically when the patient comes into the clinic, they're seeing me. You guys aren't necessarily there every day. And so a lot of my job entails teaching them and educating them and diagnosing and really creating the right treatment plan for that patient. And every patient is different and every pain generator is different. And so identifying the right treatment for each patient is important, and you and I have talked a lot about the 5 steps.
The 5 steps.
And so we include.
It was going to be 6 steps, but I only have 5 fingers.
Well, tell us the 5 steps.
Camilla, why don't you tell us the 5 steps?
So the first step is
I'm interested to see if you remember.
The first step is creating the right diagnosis.
Right diagnosis.
Now I can't remember because you put me on the spot. I'm sweating.
One thing I'll say on the diagnosis, because I don't want to just jump right over that, is it's really strange. Like you have people who've had chronic pain for 10 years, 15 years, 20 years, and a lot of those people haven't had like a proper workup.
So and that's not rare.
That's not rare. It's not
happens all the time.
All the time.
So they haven't had an MRI, they haven't had a nerve study, even though they have weakness and like other things where you're like, wow, how is this happening? And they've seen other professionals.
They have.
So I think diagnosis is like so key for what we do. Because we base a lot of the treatment plan. The other 4 fingers, we base a lot of that on on what we find in the diagnosis.
So diagnosis, we might order MRIs or CAT scans or EMG to look for nerve damage, X-rays. One that's missed a lot is flexion extension X-rays. We have a diagnosis that we see sometimes, slippage of the spine. We say spondylolisthesis. I like to say it just to show off that I can say it, but spondylolisthesis means slippage of the spine, and a patient hasn't had flexion extension X-rays, and what happens, sometimes we'll do X-rays and we see that the spine is actually unstable, so we'll do X-rays.
Well, and two, like in an MRI, I always explain to patients that they're lying still.
Right.
They're, they're motionless in the MRI, and so it doesn't always capture whether or not that slippage is occurring when they're
That's right.
So diagnosis is important, and I cannot stress enough what you said is true, Tori. Pain is complicated, and a lot of times patients don't get the accurate workup because most doctors don't know exactly what to do to work it up.
That's right.
And then the second step is medications. We like to say at our clinic, every patient is going to get some medication. You may not get opioids or strong painkillers, but something, whether it's maybe
Celebrex,
Celebrex,
anti-inflammatory or a muscle relaxer, or vitamins.
Or a cream or a rub, or like, so generally the plan is to start with the least invasive, simplest thing that might help them. And then we progress from there.
And then the third step for us is
interventions,
procedures. For some patients that have terrible spines, it might mean surgery. For some patients, it might just be a trigger point injection. Yeah, it depends on what the patient needs. But what we found in interventional pain management, and this is where Tori and I trained at one of the top programs in the country at Texas Tech, we learned all sorts of advanced procedures to help people that are suffering with pain. That's probably our favorite finger for us personally.
I mean, it's really gratifying and rewarding when you do something and it really helps somebody. And one thing, we trained at a really great program, but that was a while ago. And something that's so cool about this space, I think we knew that coming into this space, is that it was going to grow and there was going to be more and more minimally invasive options. And I think one of the analogies that I've always thought is a good one is in the cardiovascular world. If someone had, chest pain, had a heart attack, and had blocked arteries, let's say 20 years ago, they would have to do open heart surgery, open it up, crack open their chest, which we were involved in those cases in anesthesia. And it's a big surgery. And then, out came the minimally invasive options where they just go through a small, blood vessel in your leg or in your arm, and they go and they can balloon open that same vessel and put in a stent, let's say. And so I think that's kind of the future of pain management, and that falls under interventions, and we've seen that happen over the last 15 years.
Right, and going back to last episode where you talked about interventional for cancer pain, we see a lot of patients that are experiencing pain from cancer, and so being able to alleviate the pain with an intervention that's minimally invasive that can help them towards the end of life is really important.
I know that's always been kind of close to your heart when you've seen some of those patients and you told me the stories. I know sometimes it almost brings you to tears talking about the people you've helped. Is there any cancer patient that you remember this year that you felt like we helped?
Yes, I saw one yesterday, and he had like a thoracotomy and was having intercostal pain, and so I explained to him that while he was referred to us to take over the opioid prescribing, I explained to him there was a myriad of procedures that we could do to help alleviate his pain, and he was very excited about that.
It's interesting that you bring up chest wall pain. There was a study done at MD Anderson probably 10 or 15 years ago now that showed after patients went through a thoracotomy where they opened the chest and they cut away the tumor, that about 40% of them will have chronic pain for the rest of their life in their chest wall. Like, we don't think about that. Like, we cure the cancer, we get the person better, but they're going to be suffering every day. And we do some cool stuff. So Tori, like if you had a patient who had a thoracotomy and had chest wall pain, tell them about some of the cool stuff we can do.
Yeah, so there are things that we've been doing for a long, long time. So things just like, epidurals in the thoracic spine, which, not all doctors do that. Intercostal nerve blocks. She was talking about the nerves that are there. Those nerves get damaged during this surgery. And so there's a way that we can numb those up, and then if that helps cauterize those nerves, I bet that's what you ordered.
That's exactly.
And then there are some kind of other things that are newer. So in the kind of neuromodulation where you can stimulate the nervous system and basically quiet those nerves that are damaged so that you can relieve somebody of their pain.
And I actually wanted to do a deeper dive on that and ask you just to demonstrate for our audience, like, it doesn't matter what your pain syndrome is. We have spent our lives studying that diagnosis and what we can do to help them. And did we help your patient? Did you feel like we were making a difference for them?
Yes, absolutely.
That's the most exciting for me.
One thing I think is interesting is like you talk about, you know, this patient who had this surgery here, but it's interesting because almost every surgery we'll see some version of that.
Yeah.
So like you have somebody who's had a knee replacement. Most people do great, but then there are, you know, people who don't do well, who have pain, or hip surgery, or really any kind of surgery. And so those are the people you see every day and that we see.
Absolutely.
So our step 4, hands-on therapy. We try to do hands-on therapy with every patient we meet. And Dr. McChuck, would you tell us a little bit about your dad and his background and kind of how we incorporated it?
So, you know, hands-on therapy is literally, you know, something that we do that's tactile, that's helping the patient. And it may be to help diagnose their pain, but it's also to treat them. And so my dad, you know, has been doing chiropractic, acupuncture, naturopathic medicine. And so he's very, very much hands-on, where he is adjusting them or, you know, massaging them or something to alleviate the tenderness that they have. And those things are really powerful. A lot of people don't know about the research involved in those things, but it can really help people.
Oh, it makes a huge difference. And this is where I get excited, you know, to tell my own personal story. I grew up in Kentucky and Indiana, and I will just tell you, they were super negative on chiropractic care. They didn't believe in it. I asked doctors about it, and they say, no, don't deal with that. I actually hurt my back in a car wreck when I was still in high school, and I asked the doctor about a chiropractor. He's like, heck no, stay away from those guys. They'll paralyze you or whatever. And so when I came to Arizona, we acquired this practice in Scottsdale, and we have Dr. Moore was working here at the time.
That's right.
And Dr. Moore's a chiropractor, and some of our patients who are watching have seen him. Just a wonderful man. I was walking around in early 2008 with my neck, kind of a crick in my neck, and he looked at me and he's like, Dr. Lynch, I can help you with that if you want. I'm like, no, I'm good. And then a couple hours later, he's like, Dr. Lynch, just come over and see me and see if I can't help you. So I kind of begrudgingly went over to Dr. Moore's office, and he did some massage and some tissue work, took out like ultrasound, worked on it. He adjusted my neck, and literally, I felt like a new man. And I went back to seeing patients, and for the last 13 years, when my neck hurts, I go see Dr. Moore, and it changed kind of my perspective on it, right?
Well, when I was in nursing school, actually, I suffered a back injury where I caught a patient that was falling. And I was pregnant at the time with my daughter, and so I wasn't able to really undergo treatment for it, but I was referred to a chiropractor, and I did nothing but chiropractic for 18 months, and it essentially cured me. I haven't needed any kind of other procedure, so I really believe in
When I talk about the 4th step, hands-on therapy, it might be physical therapy, it might be chiropractic care, it might be massage. We have 2 osteopathic medical schools here in the Phoenix area now, and there's more and more osteopaths are graduating that do osteopathic manipulation. So hands-on therapy might be a little bit different for every person. Sometimes it's just talking with our patient to lose weight and to exercise and to get mobile again. But this finger is such an important part of our care. And then our final step is we used to call it behavioral health, but what we realized is we actually need like a 7, 8, and 9. So we just started calling this other. And so for other, some patients need behavioral health. We found about 50% of our patients have depression or anxiety when they come to our clinics, but 100% of our patients deal with the stress of chronic pain.
That's right.
So we have behavioral health, but we also do things like bracing. We have studies that we do. There's all sorts of things that we do kind of on this pinky. But that's kind of our 5-step approach to pain. And Tori, do you feel like our approach is becoming the standard of care?
Yeah, I mean, I think that's been the trend over the last 10 years. And I think, you know, one is we've learned a lot about pain. So we know that pain like affects people in different ways, but it's also like multimodal, meaning it affects like their brain, their spinal cord, their nerves, down to the muscular level. So it has this massive effect on you. And so if you just think about it like, oh, I'm going to do an injection for that bulging disc, that doesn't treat all of those different things. So you really need to do a comprehensive approach that treats all of those things. And I think that's where the 5 thing in the hand really matches up really nicely with this multimodal aspect of pain. So yeah, we've actually done studies on our own patients and kind of looked at the outcomes.
Certainly the outcomes are better in a comprehensive integrated clinic. And what's cool for me is I remember to this day watching you give that speech 14 years ago and being not really booed off the stage, but certainly kind of whispered off the stage.
Yeah.
And I think if you went back today, what you'd find is the medical community, not just in Texas, but here in Arizona, is embracing that what we're doing is the right approach.
That's
so,
right.
Kudos to you to being, on the cutting edge of that years ago.
Yeah, and that's what you'll find at most big academic institutions.
Yeah, that's right.
Mayo Clinic and, Johns Hopkins and other places they do a comprehensive version of their care.
That's awesome.
Yep.
Well, I think that's a pretty good finishing point. For you, those of you at home that are tuning in, subscribe to our channel, and I encourage you to go back and watch our video, our last episode on our story and why we got into it, and follow along. We're going to take this time to educate about pain and be a resource for you. Thanks for joining us for the Pain Show.
Thank you.
you.
Thanks.